All right, we'll go ahead and get started real quick. We're a couple minutes behind. Like I said, I'm having issues down here with this camera. But today what we're going to talk about is the nutrition care process. And I know that everybody, we're supposed to all, have a background in nutrition when we was going through college. And the nutrition care process is kind of what we base everything on. What we do is either nutritionists or if you're a dietitian or whatever. And so we're going to focus on how we apply the nutrition care process and in the WIC setting, but we're really just going to look at the assessment phase. You can go ahead and change the slide, Gwen. All right, give me somebody, and I'll call out the region first, but if I don't get nobody, I'll just call out on a clinic. So I'll give you the chance to speak up first. But somebody in Region 1, read the mission, the WIC mission, and the public health mission.
Okay, the mission of the WIC program is to safeguard the health of low-income women, infants, and children up to age 5 who are at nutrition risk by providing nutritious food to supplement diets, informing information on healthy eating, and referrals to health care. And the mission is to inform, prevent, and protect.
Thank you. Yeah, and you see, every time we do a presentation, y'all know we always do this, and I think it's just good to do that. It may seem repetitive, but we always need to remember what our mission is as public health. All right, these are a few of the objectives that we're going to go over today. We're going to talk about how we can enhance all CPA's understanding of the roles and responsibility of the WIC nutrition service standards. Also, too, what I'd like to see is our CPAs to have a better understanding of the assessment phase in the WIC setting. What does the assessment phase actually consist of? What are we doing during the assessment phase? And we're going to briefly, just touch on some of the steps during the certification process, which pretty much looking at the nutrition questionnaire and how they impact the assessment phase. And why does the assessment phase matter? What's the purpose? Why are we doing this? And then I got a small little case study for us to do at the end. This is some of our roles and responsibilities when we're talking about the nutrition services standards for the CPA. First we want to determine the nutritional risk. When we are questioning and probing and finding out about our client, what's the nutritional risk that we're looking at. Also,
it automatically
we're tailoring food package too according to the CPA. Also, too, we want to provide education responsive to the identified needs and interests of the participant. And also, we're going to develop an individual care plan. Now, the care plan is, that's kind of our goals that we're setting with the clients when we're asking them, what are their goals? What do they want to accomplish by the next time they come in? That's and how we're going to implement that care plan. And also, too, we're a referral program. Can anybody in Region 2 tell me, which I hope everybody knows, but what is our main referrals that we're required to do? Somebody from Region 2.
Hey, Ron. It's food stamps, Medicaid, and TANF.
Okay, thank you. That's correct. All right, you can go to the next slide, Gwen. All right, this is kind of the definition of a care plan. It's strategies designed to guide healthcare professionals involved with patient care. Such plans are patient-specific and are meant to address the total status of the patient. Care plans are intended to ensure optimal outcomes for the patients during the course of their care. So when we're looking at a care plan, there's a lot of steps that go on. into developing a care plan. And mainly, it all starts with the assessment phase. And a nutrition assessment is a systematic method for obtaining, verifying, and interpreting data needed to identify nutrition-related problems, their causes, and their significance. Okay, you can go to the next slide. All right, the nutrition screening phase. This is a process to identify an individual who is malnourished or who is at risk for malnourished to determine if detailed nutrition assessment is indicated. And the definition of malnourished is the insufficient, excessive, or imbalanced consumption of nutrients. A number of different nutrition disorders may arise, depending on which nutrients are under or overabundant in the diet. Also, too, when we're doing the nutrition screening, it's not necessarily that they're just malnourished. They may have other nutritional risk factors, which we document during the certification process. And then the nutrition assessment, which is really what we're going to be talking about. It's a comprehensive approach to defining nutrition status that uses medical nutrition and medication histories, physical examination, anthropometric measurements, and laboratory data. A formal nutrition assessment should provide all the information necessary to develop an appropriate nutrition care plan. Now, when you can go ahead and go to the next, yeah, right there. When we look at, doing the nutrition care process in the WIC setting, a lot of times we think about, what an RD does, for example, in the hospital when they're applying the nutrition care plan. I think sometimes that's what goes through our mind as far as like what a nutritionist or a dietitian does. But WIC is very, very clinical in that. I remember going through my internship when I had to do my rotations, and WIC is very much clinical. There's a lot of things that are very, very similar to when you go and when you observe how a dietitian works in a hospital, in a renal setting, or so on. What we do in WIC is very, very similar. The only thing we're not doing is we're not providing a nutritional diagnosis. That's really the only thing we're not doing. Everything else is pretty much the same. We're assessing the patient, we're screening the patient, we're building rapport, we're reviewing over things, we're developing a care plan. So it's very much similar in that. Sometimes I don't think we realize how similar it is. When we're doing the nutrition assessment, these are some of the tools that we use, which all of y'all are very familiar with these, but this is some of the things that assist us during our WIC clinical practice. Our risk criteria handbook, and I hope everybody uses this every day, especially when you, I know I've been working for 6 years and I still use it to this day just to, touch on things and review over things. We also have pocket references, with our, whether it's our food package. We also have the pediatric nutrition assessment pocket references. I think everybody has those. We have, all clinics should have the food medication interactions. And then we have breastfeeding and nutrition resources. And we, all of us have access to log into the nutrition care manual now. And even, hopefully everybody uses that. But even if you don't, when you got downtime or things like that, it's kind of good to look through that thing and look over some things. The nutrition care manual is it's very valuable to us, and I think we need to really start using that a lot more. Also, to our peer counselors, which I think we all do a pretty good job of utilizing our peer counselors and breastfeeding resources. And probably one of the biggest things that I think that we can use to our advantage if we use it right is the nutrition questionnaire. Sometimes I think the clients just fill out the nutrition questionnaire, we kind of touch on it, and then we go on. We can gather a lot of information through that nutrition questionnaire if we go through each part of it with the client. You can go to the next. Okay. Now this is, I kind of touched on this in the last slide, some steps to the certification as far as how it relates to the assessment phase of the nutrition care process. As a CPA, we're building rapport with the clients. We're touching on any concerns that the client has. We're reviewing over the client. And I think that's one of the big things that we have to do. We say we have a child that comes in, they're this is not their first time being on WIC. They've been on WIC for a while now. We need to review over their past records. We need to review over their previous plans. Did they reach their goal? Were they, whatever they set out to do, are they reaching their care plan goals from the last time? So we need a review on what progression they're making as their own WIC with us. We provide the assessment phase, which we just talked about. Education is probably the biggest thing we do, because we do not provide a nutritional diagnosis as a CPA unless you're working as a clinical nutritionist. As a RD, we're not doing nutritional diagnosis. So education is the big thing that we do. We're setting goals, which help to develop our care plans. Somebody from Region 3, how does a food and nutrition professional determine where to obtain nutrition assessment data? So somebody from Region 3, I want you to, just in your own answer, there's not a specific answer, just in your own answer, how does one do this? Somebody from Region 3. Or somebody in Henry County. How about that? Does anybody in Region 1 know?
Hey Ryan, it's Lindsay.
Okay.
Well, where a nutrition professional I think would get their information is number one, from the food frequency questionnaire, or a 24-hour recall, or talking to them about their usual dietary habits. You may observe the patient, so you may look for signs of, some nutrition risk if you're in a clinical setting, or you may also, of course, in our instance, you're going to weigh and measure them, so you're going to get their anthropometric data. You may look at their laboratory data, so for us, that would be hemoglobin. Those are some of the places that we would get our assessment data.
Yeah, definitely. That's our data, it can be obtained from a variety of resources and indicators, like you just mentioned. It can come directly from the patient or the client through interview or observation, like you said. Measurements, past medical records. So yeah, that's definitely. We have to utilize where all we can get our information from. All right, the assessment. The first thing that we should be doing during the assessment is obtaining the facts. It's important as nutrition professionals to obtain accurate and adequate information in order to identify the nutrition-related problems. As we just mentioned, it can be obtained from a variety of resources, but as Lindsay stated, start with the nutrition questionnaire. Really read through this, review over it when you get the client. That's one of the things, and I'll go and tell you, from when I first started working at WIC, sometimes with the nutrition questionnaire, I would just kind of briefly look through it. Now, when I get it, I know they fill it out, but I go through each step with them. I actually try to ask open-ended questions each step of the questionnaire to try to help me gather more information. And a lot of times you find out a lot more. Sometimes it's better to just fill it out with them. Sometimes, I know we let them fill it out sometimes before we get the client, but I've seen times where it's just easier when you start with the nutrition questionnaire and you fill it out as you're asking them questions, and that. So sometimes that'll help out to obtain more facts and more information from them. They say the nutrition questionnaire. We can get there's a lot of information that can be obtained through the nutrition questionnaire. Here are some of the topics that we can gather information on. We find out medical history, if they're on any medications, whether they're prescribed or over the counter, some food safety, sanitation, their feeding ability. How are they feeding? Are they having any issues with feeding? Their access to foods. Are they able to get to foods? Are they not? Or do they live in food deserts? What's their access? their dietary pattern and their history. You know, what does a day-to-day look like for them? What from morning till night? What does their dietary pattern look like? Their feeding practices. You know, whether it's a child or an infant, how are they feeding the child? Medical care. Is there any medical and dental care being provided? What's their physical activity level? Are they having any gastrointestinal issues? Is smoking and alcohol in somewhere, you know, related anywhere? So, these are huge. You can get a lot of information from these, and this all comes from our nutrition questionnaire. So, I think if we really need to start focusing on the nutrition questionnaire, because that's more than enough information that we need to help develop a care plan with the client. Now, when you're going through the assessment, when you're doing the nutrition questionnaire and the whole screening and assessment with the client, you know, you got to use some critical thinking during this step. You want to determine the appropriate data to collect. You know, sometimes we have to distinguish relevant from irrelevant data. Sometimes we tend to focus on the wrong things, and there's not, you know, one thing that's right or wrong from the other when you're gathering information, but we need to find out where we're putting our focus on. For example, if we have a child that comes in and, you know, they're having swallowing difficulties, you know, having issues chewing, things like that, the client's not gaining weight because of this, their hemoglobin's low, possibly because of this. If that's, you know, we see that's the big issue that's going on with this client when we get them, we don't want to focus on necessarily why the child won't eat more meats. You know, that's important. You know, if the mom brings that issue up, that is and that's a concern with her that she can't get her child to eat more meats. Yeah, we need to touch on that. But does that seem like it's more important than, you know, the child having swallowing difficulties, issues gaining weight because of it? So you know, that was just an example, but I think that's, you know, we need to focus on really where we're putting our focus at during the assessment. Also, too, you know, selecting what assessment tools and procedures that match the situation. You know, and also validating the data. You know, we got to make sure that everything's correct. Everything that we're looking at matches up. All right, here's some, as far as for the CPAs, just some key points to remember. Nutrition and education, of course, is the main purpose for the WIC program and should be the forefront of service delivery to the clients. The vouchers and supplemental foods that we supply, as we all know, those are just secondary benefits. We have a legal and ethical responsibility for the care that we give, and probably most importantly, don't give. I think that's one of the big things we need to remember is it's not just always about the information that we give the client. Sometimes the information that we don't give the client may be more important. And most importantly, our job is very important, and what we do and say matters. I think that's the big thing. Sometimes, you know, we can come to work each day and it becomes routine. It seems like it's the same thing over and over and over again. And each client, and I know things, I've worked in a busy clinic, I've worked in a slow clinic. Sometimes when it's real busy at a clinic, it's kind of hard, you know, to touch on each step of the assessment process like you would want to with a client. But each client is a new story, you know, and that's how you should treat it when you get a client. You know, each one's a new one. You know, really try to give them the best care that you can. And I think that's, which, I mean, I've been guilty of it too before. When you get so busy, you know, you're trying to hurry up, get this one done, and get to the next one. And, but we really need to, I think, focus on the care that we're providing to each client. We're going to do a quick case study. I know we got started a little late, but we'll go ahead and try to do this case study real quick. Let's see. All right, for our case study, we have a client that is 18-month-old full-term female. The weight, and since I know we do electronic growth charts now, so you're not going to have to graph this, so I kind of provided the percentiles for you. But the weight for this 18-month-old female was 26.5 pounds, which is right in between the 85th and 90th percentile weight for age. The height was 29.75 of an inch, which is between the 2nd and the 5th percentile. I think it was like right at the 4th. And then head circumference is 18.5 inches, which is right at the 50th percentile. The weight to length was above the 97th percentile, and the hemoglobin for this client was 10.4. And on the next slide is the nutrition questionnaire. Now, I think hopefully everybody printed this off. But just looking through this questionnaire, somebody from Region 1, like, what are some things you can tell me about this, or what the CPA needs to do right here, just from looking at this questionnaire? The client's already filled it out, or the client's mom has already filled it out. What's some things you think the CPA should do when first looking at this?
I would definitely go over some of the things with moms to make sure that she understood the questions, because a lot of times when we assume that, the child is, drinking soda every day or Gatorade every day, and then you would want to double check to make sure that the 18-year-old is drinking from the bottle as well. So definitely there's other things on there, but I would definitely talk with mama first before I started documenting things.
Yeah, definitely. That's the big thing. When we get this nutrition questionnaire and we see that, yes, she's filled everything out, we don't just need to sign our name on it and start the assessment. Like you said, we really need to go through it. We need to find out, how many times are they using the bottle a day? When you get down to, what does your child eat? The foods that they eat. Do they never eat vegetables, or do you ever? How many times do you offer the vegetables? So that those are some things that we can find out right there. The milk, the fruit drinks, the soda, the Gatorade and tea that she checked. How much? That's the thing I want to know. How much milk are they drinking a day? How much soda are they drinking? How frequently are they drinking things? So we need to really start documenting a lot on the nutrition questionnaires. Our nutrition questionnaires should have a lot of not only their documentation, but our documentation should be on there too. We should be writing out to the side, because, for example, when they come and do audit, as y'all know, everybody's been through an audit. When they come and do an audit and they see this nutrition questionnaire, and then you've marked that they're consuming excess sugary drinks, but then when you look at this and you don't provide documentation on how much are they drinking, are they drinking 2 cups a day? Are they drinking a cup a day? Or are they only drinking it one time a week? So that's some things. We need to start providing a lot of our own documentation along on the nutrition questionnaire. You can go ahead and go to the next slide. Kind of keep that with you, though, to the side if you printed it out, because you may need it to help you answer some of these questions. All right. When the child came in, the child was observed in the office carrying a bottle around that appeared to be Coca-Cola in it. The mom states that the child never eats veggies unless French fries count. Mom states the child really doesn't like to eat. The child would prefer to drink the bottle all day long, so she gives her a bottle because, I don't know why it printed out like that, but because at least she is getting something. She will not take a nap. She states that the child drinks 4 8-ounce bottles of whole milk per day, along with 4-ounce sippy cups of water or juice at meal times. This messed up all when I was printing. Child's diet is mostly fast food or prepackaged convenience foods. You can go to the next. As far as the mom, she states that she's concerned about her child's appetite. She does not understand why the child will not eat. She thinks that must be the way why the child's hemoglobin level is low. And also, she asked the CPA if Pediasure would help. Mom seems willing to change, but gives in to the child when the child cries or won't eat. So pretty much she's giving the child what she wants when the child starts crying or whining. We'll go ahead and go on to the questions. Somebody from Region 2 comment on the child's growth. Based on the measurements that were provided, what are some counseling topics or discussion topics that you would discuss with the client based on the child's growth? Somebody from Region 2.
Hey, this is Fayetteville.
Okay.
I would point out to her where the child is falling as far as weight to length goes, and ask her if she's already said she's not really comfortable with the child's eating habits, and let her know that all of the sugar that the child is taking in could be disturbing her ability to follow her hunger cues. So maybe that's why she's not eating the way she wants her to, and excess sugar is going to encourage her weight to kind of just spiral out of control.
Yeah, definitely. Those are some good topics. One thing too, I'd like to look at when we, in this client for this situation, what did they look like when they was a year old? Where was their weight to length ratio when the child was a year? Was it within a normal range, or was it above the 97th percentile when they came in at a 1? What was the progression? Did they gain a ton of weight since then? Or, their weight to length ratio percentile, did it increase dramatically? Did it come down, actually, maybe from where it was? Was it super high when she came in at 1? Also, she had stated, which this can be talked about in one of the other questions, but she stated that the child is consuming, a lot of milk. 4 8-ounce bottles of whole milk per day is a pretty good bit for a 18-month-old. So, and then she's also stated, that she's consuming some juice at mealtime. So, that may be another topic that could be talked about with the weight to length ratio. So, yeah, you can talk about a few things with the child's growth there. Somebody from Region 1, comment on the child's biometrical data. Based on the data that was provided, what counseling topics could you use?
I have low iron, so we could talk about ways to increase foods in the diet that would help the iron go up, and then talk about things like the tea and the coffee blocking iron absorption, and then things like vitamin C helping absorb iron.
Yeah, those are definitely some topics. What is something else that could possibly be affecting the hemoglobin? Any reason?
Hi, this is Lisa out of Carrollton. Also addressing when does mom planning on weaning baby from the toddler from the bottle, because that could be addressing what's contributing to the milk anemia.
Yeah,
well, milk anemia can be a contributing factor.
Yeah, definitely. That's that can play a factor in our hemoglobin levels. Overconsumption of milk, drinking too much milk, can actually impact our hemoglobin levels too. So that'd be definitely a good topic to discuss with her. Somebody from Region 3, or Region 2, what are the child's risk factors? What are some risk factors that you notice from looking at everything? What are some that you'll notice?
Hi, Ryan.
Yes, I called on too. Go ahead and go Region 3.
Okay, well, this is Maseret from Henry. Hello?
Okay.
Can you hear me?
Yeah, go ahead.
Okay, all right. Well, low iron is one.
Okay.
And high weight for lungs is another.
That's correct.
I think that's it. That's all I have.
There's one, possibly two more.
What about no height?
Routinely feeding sugary drinks.
Routine, sugary drinks maybe?
That was the one that could be possibly. There's one other definite one, but that one's possibly because Why is it a maybe? Why is it not a definite?
Well, okay.
Trying to use your critical thinking skills here. What does it go back when remember when I was talking about just touching on the assessment as a CPA when we're doing the assessment? What is one of the things that we should do during the questionnaire?
We need to ask her maybe how much the child is drinking. We know about the Coca-Cola, but maybe asking more about the tea and the...
And if it's every day, too.
Yeah, and if it's every day.
Yeah, you're right. You're correct. You're on the right track now. That's definitely, it goes back to the CPA really probing, really digging during the assessment, finding out on the nutrition questionnaire and documenting how much, how frequently. So yeah, we gotta make sure that we're actually putting a lot of information on this nutrition questionnaire and not just letting the caregiver or the parent check off. Let's try to find out how much. The other one was short stature. They're not high risk for short stature, but they are short stature, and so they was right below the 5th percentile.
Hey Ryan.
Hey.
Hey, would you address the choking hazard since she's 18 months old with the grapes and hot dogs? Maybe
that was the other part. I would find out how is she offering them. Is she, are they sliced up? How is she giving those? Because that was the other one that was that could be a possible choking hazard. That one and the sugary drinks and also the bottle. Is it a routine use of the bottle? That was the other one. There was 3 possible ones under the risk 400 that could possibly be a risk factor. So yeah, thanks for reminding me of that.
Okay.
All right, somebody from Region 1, based on the information given, and let's say that you talk with the client, what's a goal and a plan that you can use? Now, I know I put a PES statement, so I'll let one of our new RDs or any of our RDs write a PES statement right here for me. But first, one of the CPAs, what's a goal and a plan that you can develop? Yeah, go ahead.
We can really start looking at what mom is concerned about, really foremost, looking at the VINA approach, looking at what is really on mom's heart, and then we can go from there setting the goal. In this case, we could look at maybe weaning from the bottle. Like starting the day, mom will attempt to wean from the bottle by maybe offering only water in the bottle, or transitioning more to a sippy cup usage. Or we could set a goal, maybe starting the day, mom will increase or decrease the amount of milk offered to the child by maybe 5 to 6 ounces per day, or one less serving a day of the milk.
Yeah, good job, David. Yeah, there was a variety of goals and plans that we could set with this client, but you gave me the answer that really what I wanted to hear is what's the mom's true concern with the risk factors that we found out, and that try to kind of build a plan off of that. Now, one of our RDs, let's develop a PES statement right here.
Hey Ryan, it's Lindsay.
Okay.
There's a couple that we could do. They've got the altered nutrition related lab value, but I think the bigger, more upfront problem that is the bigger priority is the mom's, because you could also go excessive oral intake of like milk, and you could do inadequate intake of foods like that are high in iron, but I think the bigger picture is poor food choices related to, and I don't have my ID&T right in front of me, so I'm probably not quoting this correctly, but related to harmful beliefs or attitudes about food, as evidenced by the child is on the bottle, the child has excessive milk intake, the child has poor appetite due to drinking all day, hemoglobin is 10.4. So that's kind of the direction I think I would go for the primary PES.
Yeah, that was kind of my thinking too. You know, like undesirable food choices related
Right.
to, you know, lack of access or to prior, you know, accurate nutrition information. So yeah, that would have been. There was a few of them that you could have did, but that was the one I was on the same lines of thinking as you. That was more appropriate. And that anybody else have any comments on that? What they may have chose? Or was
Hey,
that
it's
pretty?
Harley. Yeah, I think I would go also with the undesirable food choices, probably related to food nutrition knowledge deficit, and then evidenced by hemoglobin 10.4, excessive milk intake. There's a gamut of things you could have chosen.
Yeah,
as
yeah, they had there was a laundry list of signs and symptoms you could have used right there. So yeah, good job on that. We'll go ahead. Does anybody go to the next slide? Does anybody have any questions? Now, I know we kind of touched on a lot of things briefly. This was just, you know, when you're doing the nutrition care process, the assessment phase is just one phase, and you could spend hours going over, you know, this step. But I just kind of wanted to touch on a few things, you know, as far as how the assessment phase relates in the WIC setting, because we definitely perform the assessment phase when we're in WIC. We'll go to the last slide. Somebody from Region 1, I want you to, all right, I'll go. I'll read this last quote. And this, you know, of course, you know, we're really trying to implement our good to great model. And this is a quote by Clint Eastwood that I like. Sometimes if you want to see a change for the better, you have to take things into your own hands. And I think that's very true. You know, sometimes we just can't sit back and watch. You know, if we're going to do something and we want something to get better, and sometimes we just have to do it ourselves, and that we have to take our own initiative and responsibility. But I want to thank everybody for attending. Does anybody else have any questions about anything?
Hey, Ryan, it's Gwenna.
Hey.
You did a good job. I wanted to remind everybody to please answer the evaluation. I'm going to send it out right now, so when you go back to your desk, you can log on and go ahead and answer it real quick. Thank you.
Great job, Ryan.
Appreciate it.
Good job, Ryan.
Thank you, Ryan.
Thank you.
Frida, do we need to cut it off and cut back in, like you said?
I'm sorry.
I think so, David. Let me call Julie to make sure, though.
Okay.
Okay. While Region 1 is all on here, did any of y'all receive the sign-in sheet from us last week?
I
sent it to
started one and sent one to Carol.
Okay. And,
I sent it to True. I need to,
right, and then we sent it somewhere, but Geneva was asking for it, and I think I sent it to her, but I couldn't remember exactly who I sent it to. So I just wanted to make sure it wasn't one of y'all.
Yeah, wait for them to.
Upson did not receive one.
Region 1.
Okay. Geneva, I'll resend it to you if I still have it.
Okay, thanks.
Okay.
Well, I thought y'all were initiating me into Region 1, so y'all made me start off. That's what I got from the email.
Yeah, no, I got it from Carol, and so but we sent it, but I can't remember yesterday, so I don't remember who I sent it to.
I feel you, man. I feel you.
So I'll have to go back and check, Geneva. If I didn't send it, I'll send it, or I can send it again.
Okay, who sends it to Upson since we have Upson now?
I don't think anybody sent it to Upson. If I was going to send it, it was probably to you, Geneva.
Okay, well, when you send it to me, I can send it to Upson then. I guess we'll just start doing that.
Okay.
Thank you.
So I guess we're waiting on.
Lindsay.
Yes.
Geneva and David. And Erica.
Yes, ma'am.
Erica on.
Yes, I'm here.
Everybody disconnect, and then you all should be receiving a call in the next 5 minutes. Julie said we need to disconnect.
Okay.
All right, thanks.
Hey, David.
Oh, okay. You see it? Okay. It was saying recording.
Yeah, we can see you now.
Okay. I'm gonna be back and forth. I got people here already.
Okay.
So I'll be a little bit back and forth.
Okay, Frida, are you on?
I am.
Okay, is Upson on?
Yes, Upson's on.
Okay, Geneva, are you still there? Geneva? Okay, Geneva might have left, but Frida, do you want me to go ahead and get started?
Yeah, go ahead.
Okay, this isn't going to take very long. I wanted to touch base with everybody to talk about, especially since Ryan was doing the presentation that he's doing today, to piggyback off of him about the risk criteria, what we're looking at as far as the risk goes while we're doing the assessment, and then especially what we're documenting as high risk. When I've been reviewing charts, I've been noticing a lot of mistakes, and I don't think that they're intentional, obviously. I think it's probably just an information issue. We've got a lot of new people, and this is a good reminder, too, for those of us who've been here for a while. But I want to first and foremost remind everybody to look at their nutrition criteria risk handbook. It's also in the procedures manual, so if you don't have the book right with you, I prefer just to search it in the procedures manual. But make sure that, first and foremost, what we're documenting is actually a risk. So I'll give a really good example. I had a chart not too long ago where I picked it up and the mom came to me for a high-risk assessment. The only risk that she had that made her high risk was a nutrient deficiency disease, and it was documented as anemia. If you read, first of all, we assess hemoglobin and hematocrit, either one, whichever one we have. And so we're automatically going to have that risk 201 if that hemoglobin shows up low. In this particular instance, the hemoglobin was 14.7. So this mama didn't even have a hemoglobin risk. But if you look at the nutrient deficiency diseases, it's going to be more things like chelosis, scurvy, osteomalacia, Menkes disease, these kinds of things that are the insufficient dietary intake of macronutrients. So, this wouldn't be where we would document the anemia unless you got a specific document from the doctor, like a script that said anemia secondary to, renal disease or something. But they're already going to have a low hemoglobin, okay? So that was one thing. And then to piggyback that, there was documentation of harmful dietary supplement intake, and then the documentation for that was iron pills for anemia. So it would help, I think, if we just look through the nutrition risk criteria book, make sure you're familiar with that, and find out what exactly needs to be documented. So, for example, in a different instance, I had one, this person wasn't high risk, but they had inadequate prenatal care. And if you look in your risk criteria handbook, it's going to ask you to document the week's gestation at which they received their first prenatal care. The documentation was, didn't know she was pregnant. So it's just things like that that if we get audited, it's going to be, it's going to be noticed and it's going to be documented. But how that affects them even greater is if they're made to be high risk and they weren't high risk in the first place. So definitely make sure that we're looking at that risk handbook. The second quick thing that I want to address is, we all need to use our professional judgment. We're all health professionals. We've got the schooling that it takes to get this information. So I want y'all to be confident in your discretion when you're counseling a client. But I don't want you to be so overly concerned that you might miss something that you're now documenting things that really aren't that much of a problem. One of these that I see a lot is with the GERD, with the infants, the gastroesophageal reflux disease. Every single baby has GERD. And I think y'all probably noticed that. When mama comes in, if they don't mark the spitting up, they're going to mark GERD almost every single time. When they are labeled high risk, they need to have a nutrition-related risk problem. So when they come to me, there's a lot of things I can't do anything with. If they come to me with a risk that's not really a risk, I can't do much with that. I can't write a diagnosis statement. I can't even really make a plan on that, and we've kind of wasted mama's time. So just be really careful with what you're considering risk factors. A good one that a lot of our clients put down is asthma. Almost every single child has asthma. When it becomes a problem that we need to follow up with is going to be if it's nutrition related and something that we can help them make a goal with to decrease the signs and symptoms of that condition. So if you've got a baby that's got, say mama marks GERD on the questionnaire, definitely go through with her and ask her, hey mom, describe to me, I see you marked GERD here, that your baby has reflux. Describe to me what's going on with that. Tell me a little bit more about that. How often is the baby having these problems? Is the baby vomiting the whole bottle? If you see some signs and symptoms that this is nutrition related, such as weight loss, or such as refusing to eat because it's so painful for them, or aspirating, they were hospitalized, those kinds of things, definitely document that, because that is, there is a need for follow-up with that. If a doctor gives you a script that has GERD on it, you have no other choice but to document that GERD at that point, whether you feel like they have the GERD or not. They may give you a prescription for Alimentum. They'll have milk protein allergy and GERD. Well, they were already going to be high risk anyway, so just document the GERD. It was there from the doctor. So that is totally appropriate. But, in the case of asthma or even sleep apnea or, some of these other things that they might bring to the table when you ask do they have any health problems? Oh, yeah, they have asthma. Are they taking any medications for it? Yeah, they take albuterol. How often do they take the albuterol? Oh, when they have a cold. Okay, well, that's not really nutrition related. That's not something that's affecting them daily. If they've got such severe asthma that they're on a steroid daily, it's affecting their eating habits, their calorie needs are higher, maybe they're having some weight issues because of it, then for sure document that, okay? I just wondered if anybody had any questions about how to assign risk, what constitutes high risk, any issues that you're having currently in the clinic. If y'all have any questions, you can go ahead and open those up right now.
Hey, Lindsay, this is LaShonda. I have a question.
Yeah.
I was wondering if you can clarify on one of the ones for a mom who was postpartum. Because quite often I've had charts that say like for a C-section, but it just says like flare-ups or something. But correct me if I'm wrong, but I thought for a C-section it had to have like some type of nutritional implication, like if they're having like problems eating or something like that. Like,
yeah.
Would that? If it's just like the C-section and they're just fine, can I just like document in the comments or something? That wouldn't be really considered a risk.
You're totally correct, LaShonda. If they've had a C-section, no longer makes them high risk, just a C-section alone. And then of course remember that it has to be within the last 2 months.
Right.
If they have a C-section and they had a complication from it, say they got an infection, they were hospitalized, and they lost a ton of weight. You know, if you feel like that's a problem that they're dealing with, they've got higher nutritional needs because of this infection, you can document that. You know, if there was something more going on than just the C-section, for sure you can document that and make them high risk. And if you decide to make them high risk and they're not technically labeled high risk, document that. Documentation is everything, because if the chart gets to the CPA or to myself, for example, or to Ryan, because I think he's doing UPSN, if the chart gets to that person to do the high risk assessment and they look at it and go, well, this one's not high risk, I don't know why they said high risk. If the documentation is there as to why you needed a follow-up with that client, then that's definitely adequate. You know, if the documentation is everything. So, you know, y'all have all heard, if you don't document it, didn't happen. Well, that's totally true. When it gets to that second professional and they can't find the documentation as to why that high-risk assessment was needed, they're just going to say, you know what, mislabeled, and they're going to put it up and they're going to not even look at it again. So definitely make sure. There's also a couple issues that Mandy and I have been noticing with the computer, and it doesn't happen every time, but sometimes it won't assign that high risk like it's supposed to, or it'll assign something random. Like the hemoglobin will be 12.1, and then you'll get over there and it'll put the 201 risk in there. Or I've had a couple times where the infant is like 7 pounds something at birth, and then the large for gestational age was checked when I got to the criteria. So definitely try to keep an eye on, you know, the computer itself, because sometimes it does weird things as well. So definitely use your discretion. I don't want y'all to feel like, oh, well, she's probably not going to want me to mark this high risk, so I'm not going to. No. If you feel that this person needs a follow-up because it's a nutrition-related problem, as long as you document it, it's not a problem. Just, I don't want y'all to feel like you have to document every single little thing that they have going on with them, because some of them aren't going to be nutrition-related.
Okay, thank you, Lindsay.
Yeah, no problem.
Hey, Lindsay, it's Alyssa. I have a question real quick on documenting. On the HRN forms that we have, because as far as I'm aware, you're not going to be able to see those, correct? Like if you're looking back to an HRN that someone had something already, and they're like back again, like they've always had low iron, like you wouldn't necessarily be able to see that, or will you be able to see that?
If I have the chart, I would, but if I'm doing it via the VIX, I'm probably not going to see those forms, because I'm going to be mostly in the electronic chart.
Yeah, and Lynn said that. The only way you will be able to do that, of course, is to go backwards to view the previous certs. So that may be something that may be best practice when you're doing it via VIX.
Right, absolutely. But I won't be able to see their HRN forms, though, because those are only in the chart.
I was going to ask if, like, we know we're scheduling an HRN for, like, high weight for length or something that's continuously been a problem. Do you want us to document that like in the nutrition ed screen so that you can see that it's been continuously a problem?
Yeah, the nutrition ed screen, if you want it to be part of the permanent record, is the best place to do that. Some of those comments on the second and third page of the WIC screens gets deleted when the clerks make new comments. So if you want something to be part of the permanent nutrition record that is seen, like for example, if you can't locate them in grits, I do that often. I'll put on the nutrition screen, couldn't locate them in grits, referred them to the doctor or whatever. So if you want it to be something that will be seen next time and won't get deleted somehow, the nutrition screen is the best place to do that.
Okay.
All right, any other questions about anything? I know I went through that really fast, but I know y'all have clients coming in, so.
Well, and I did want to just reiterate that you all are nutrition professionals, so definitely, like Linda said, use your own professional judgment when you're determining whether someone is high risk or not, and double check the computer. Of course, it will make errors, so sometimes we just have to double check behind our own selves. So if you notice that if you have a gut feeling or you really want to follow up with someone, it's just you just definitely have to document why, because the person coming behind you won't know what's going on unless you do so.
Yeah.
So that was just a great point, because I have had clients where they weren't high risk on paper as far as the assessment, the WIC certification goes, but from my visual assessment of them, or just actually having a conversation with mom, I wanted to see them back. I wanted to bring them back, within a month or two, just to check up on them. So, but you have to document why. It has to be documented.
And Frida, also I was wondering if there's an instance where, say they're not that you don't think that they would necessarily benefit from RD services, but they were kind of on that borderline where, I really just wanted to see them again. Can they ask the clerk to put them in an NHRN slot versus an RD slot? Like if they're not technically a high risk, or if somebody wanted to personally follow up with somebody, like.
Especially if it's something where you feel like you want to see that person, like if it's a high risk that's not, if it's somebody that you personally just want to see back in the clinic, then definitely it needs to go, instead of being referred to Lindsay via VIX, it needs to be, referred back to you. And you can put a note on there, please refer client back to me, and schedule them for the NHRN versus the RDH.
Right. And a good one that I've had that instance before, and a good example of that would be a mom that's got a new baby, and I was concerned about how she's mixing the formula. Baby looks fine, weight is fine, baby's alert, everything looks fine, but I'm really concerned about that formula situation. Like, I don't know if mom understands. Does she need a ready to feed? Is there a mental incapacity there?
Right.
I might bring somebody back in 2 weeks or a month, and that would be a good thing to assign them to, if being back in the clinic face to face with a nutritionist.
Yeah, 2 weeks is fine as well. As long as and you can communicate that with the clerk. The clerks can prorate vouchers, so if you need to bring somebody back within 2 weeks just to follow up on them, just to have a visual assessment of them, then just tell the clerk to prorate them for 2. Of course, communicate that to the mom. Just say, I just want to follow up with you. Just try to develop that rapport so that she won't think she's coming back in the clinic, too often for nothing. Express to you that express to her that you care. It's all out of you caring about, the health of her or her baby. So in most cases, the moms are not going to be like, they're not going to deny coming back. They're going to be as concerned as you are.
Right.
So,
the only other point that I want to make is I'd had a couple of referrals for weight checks for high weight for length for infants. I don't think we need to be checking up on those high weight for length. Some infants are just high weight for length. If you think there's an overfeeding situation, definitely that's a counseling point between you and the mom. But if they say high weight for length, in their 6-month appointment they were high weight for length, and at their 1-year appointment they were high weight for length, but they're following a curve, I don't think that that's a good reason to bring them back for an HRN and reassess them. I think that they could probably benefit more from some other nutrition education through the classes and whatnot versus talking about, how chubby their baby is. So that's just another, of course, your discretion always is welcome. But just keep in mind, the big picture of the nutrition risk type situation.
Okay, and just in closing, I want to say all high-risk clients are going to be referred to Lindsay or Ryan unless you all specifically want to, or unless they come in for various services for the same family, and then they may be referred to the clinic CPA, or unless you all want to personally follow up with that client, because you do develop a relationship with some clients that you want to see them back. So, but in all other cases, like I said, all the high risk follow-ups will be referred to Lindsay or Ryan for the most part.
Frida, I had a question about that, because some high risk you may have like short for stature. You may have parents, it may be genetically linked with that. So will we still refer like certain, risk factors are not typically severe high risk? Will we still refer those to Lindsay? And
yes. It's not much that can be done when it's a genetic when it's something that where mom and dad are both short, but it's just the policy that we're District 4 is using now is that we're utilizing the dietitians as much as possible for the high risk follow-ups.
Okay.
And also, Frida, can I say something else about that as well? I know before I went through the internship, I used to look at the short stature and go, oh my goodness, I wish this wasn't even a risk. This is so ridiculous. Mom and dad are short. But short stature can be an indicator of long-term malnutrition. So if we've got a client who has been undernourished for a long time, it may not show in their weight or their weight for length, but it may show in their stature. So I think that even though, of course, it is our policy, but also it is a good idea to maybe get a little further in-depth assessment to make sure that, are they having chronic malnutrition, or is this just a mom and dad are short and this child is never, is their genetic potential? So I would like to see those anyway.
Okay, so to clarify everything, so risk factor 201 and 121, short stature and hemoglobin, now need to be seen by the RD.
Yes, absolutely.
Okay, because we were doing it differently from the old region a little bit. Okay, just clarifying.
Okay, yeah. I can go ahead. Sorry, I didn't mean to interrupt you.
I was thinking too, certain food allergies are critical. But let's say if it's something like maybe pineapples or still, that would be a referral to the.
If it's. I don't know. Right now, as far as food allergy, Lindsay, read that risk criteria that goes along with food allergy.
Okay, let me find it. Hold on one second. You talking about for children, or does it matter?
Yeah,
let me find it for children.
I would do it for just go ahead and read it for children. It should be the same for all types.
It's going to be grade 40. Food allergies. Okay. So, an adverse immune response to a food or hypersensitivity that causes adverse immunologic reaction. This is just defining it. Presence of condition diagnosed, documented or reported by a physician or someone working under a physician's orders, or is self-reported by the client, applicant, participant, caregiver. So for documenting, you're going to document the diagnosis, the name of the physician who is treating the condition, and the participant's health record. The high risk is only a diagnosed food allergy. So if you've got a prescription that has the doctor's documentation that they have a milk protein allergy, that's a high risk. If you've got some other document from, I don't know, say they were at Children's Healthcare of Atlanta, and the doctor writes on the script that this child has a severe wheat allergy, then that's going to be a high risk. I was actually going to point that out, and I'm glad you asked that question, because I can't even make a PES statement on a food allergy. When you look up in the nutrition care manual the different reasons why you might the different diagnoses that you could use, nutrition diagnoses, it's all inadequate intake, excessive intake, poor food choices, food and nutrition related knowledge. Most of these patients, if the baby got a rash because of bananas, they're not going to give the child bananas, So it's really hard for me to even assess that client when they have I don't even really know what to talk about with them except for make sure you avoid these foods. So just make sure you know that make sure you check that box because it's going to check at high risk automatically because it's in that 340 risk code. With the medical problems, it's automatically going to check it. So make sure if they've got, excuse me, I had one yesterday with the bananas, with the baby food. Baby had a reaction with the bananas. If you check that as a mom reported the food allergy, reports rash when eating bananas, it's going to check that high risk when you go onto that last screen. It's going to change it from an N to a Y. And they're automatically going to be flagged high risk, and then the clerks are going to be asking you, how come they didn't get a high risk? So make sure you change that Y back to an N if it's not documented from the medical provider.
I did that one time, and the clerks got an error. They were trying to print. Have y'all experienced that? That when you change a risk factor that's suitable for high risk to a no, that the clerks will have a problem printing. I had that happen a few times.
Have you?
Did y'all have that happen?
I have not experienced that, but they may need to pull the TAD up and make sure that all the codes in the TAD are correct. And if they have further problems, I would probably contact Casey or Frida.
Okay. Yeah, it was a while ago, but I remember it was last year, late last year, we had a few instances like that, yeah.
Yeah, and these computers, y'all, they do crazy stuff sometimes, I promise you. I know sometimes the clerks think I'm crazy, but I'm like, I don't know why the computer did that. You just have to check behind it sometimes. It'll do weird things sometimes.
Okay.
All right, you guys. Thank you, Lindsay.
Thank you, everybody. Y'all have a good day.
Frida.
You too.
Y'all have a good day.
Frida.
Uh-huh.
I have a quick question.
Okay.
Am I, who's doing my high risk? Ryan?
Yes, Ryan is going to be doing high risk.
So I need to go by the referrals, his rules and regulations when it comes to referring to our RD, right?
No, Ryan, there was I think there was a document that was sent out that had specific risk criteria for your region at the time. But no, everybody's under the same protocol where all the high-risk participants are referred to the dietitian unless there's a reason not to. Like if they're coming in with a family with multiple services or if the CPA personally wants to see them. Okay?
So disregard that documentation.
Yeah, disregard that. That was prior to all these changes being implemented. So disregard that.
Okay.
All right, thank y'all.
Okay. Thanks. Bye-bye.